Hi everyone, I wanted to add this little video along with the study guide that I posted this evening as well. The study guide's pretty straightforward, it's for test one, but I wanted to point out some things about delirium and dementia that I think are important. Um, I also posted a document from a book. Y'all may have that Tootsie book, but if not, it's a document. It's a document that I made, but it's from one of their tables, and so I thought it was beneficial. So you can take a look at that. I posted that in the module earlier today. I want to point out a few things about delirium and dementia. If you're seeing patients in the hospital setting, you'll probably be called to see patients on the medical floor with possibility of delirium. Um, Remember that dementia does not develop quickly over 1 to 2 days, but delirium does. Patients with dementia can be at a higher risk for delirium, but that does not mean that all of a sudden they came in the hospital and they developed dementia. That's not how it works. But it can be very complicated. Sometimes the patient has not been diagnosed with dementia in the past when the family does not recognize the signs and symptoms, but they have that. But um, it's inappropriate, I think, to document that or diagnose that when they're in the hospital in an acute care setting. Period. The hallmark sign of delirium is impaired consciousness, and I've put this on test before, and everybody seems to miss it. It is not on the test this time, I do not think, but that's per Kaplan Sadik, not me. It's when you have um, impaired consciousness and you have this global impairment. So you have impairment in various areas. There's a table on page 228. It's table 3/5, and it summarizes the symptoms. But I want to go over with you now. You'll have a altered level of consciousness. You'll see that the patient is not attentive. They're disoriented. They have impaired memory. The symptoms are rapid onset, and it's an unpredictable or difficult to determine what's going to happen next. Lots of fluctuations with the patient with delirium, and it can be worse at night. So the table did not address what we get called on a lot, and that's agitation. And the patient can become agitated because they may be confused, they may be scared, they may be paranoid, they think somebody's after them. That's what I hear a lot. And so they may be thinking that the nursing staff is trying to harm them by simply putting in a IV or changing a catheter or even bringing a food tray. There are several tables I want you to pay attention to in Kaplan, and I did not go through every detail of those tables, but pay attention to them. It's table 3.6, 3.8, and 3.11. The first one, 0.6, shows you some physical symptoms of what may be the cause of the delirium, and you can hopefully resolve the physical problems, and then the delirium will slowly resolve. Well, will resolve, hopefully not slowly, but sometimes it does take a while. 3.8 is a table which contrasts the differences between delirium and dementia, and I think that's very, very important to look at because we know that we can treat that delirium and it's reversible. The dementia, of course, is not reversible. 311 shows you some risk factors for the patient who may develop delirium. So if you get this patient in the hospital for whatever reason and they have all these and they're confused and not at baseline, look at these risk factors and say, hey, could this be a delirium? And if it is, why is this delirium developing? And those symptoms, those factors, the risk factors can be older than 65 years old, male sex, a previous diagnosis of dementia, depressive symptoms, somebody that's not very mobile and high risk for falls, someone who comes in with a hearing or vision impairment. Sometimes we know that patients don't always bring their hearing aids to the hospital or to their glasses, and so that will cause some problems and increase confusion. If somebody comes in malnourished or dehydrated, that's a risk factor. Alcohol abuse is a risk factor. Anticholinergic meds like the Benadryls and all the PMs that people take all the time now to help them sleep, and then just a variety of medical conditions that can be risk factors for these patients. Remember, speaking of alcohol, remember to assess your older patient for alcohol and drug abuse. I see a lot of people over the age of 65 that are using alcohol and marijuana, especially as far as the drugs. But I do have people who are over 60 who are using marijuana, alcohol, cocaine. And so when they come into the hospital, it's difficult to determine, is this a result of them being intoxicated on something, or is it something that they're withdrawing from? Like if they're using a lot of benzodiazepines or alcohol, they could be in withdrawals. And so that's going to be treated a different way. What we see most often with delirium is some type of infectious process. And of course, the infectious process can usually be identified and corrected, but we also see polypharmacy being a problem, and over the counter meds and things people buy. I have some older people that have been using lots of Tylenol PM, Advil PM. Of course, that's Benadryl, and they use those to help them sleep. I've had people use, not just older people, but younger people too, a lot of the stuff that's available now at the drugstores. At the gas stations, and I've had some people recently with kratom that are in the older population. I even had a lady who was taking really high doses of melatonin to help her sleep, and that was the only thing we could figure out what was causing the confusion. So just ask about those over-the-counter meds as well as prescription medications. As far as your test goes, the test questions are pretty straightforward, but I want you to remember that a delirium is reversible, and so we need to educate patients and families and even caregivers in the hospital that it is reversible, and as the medical problem or the problem that's causing the delirium resolves, the confusion should resolve a lot as well, because when patients come in, their family members are usually very, very distraught over this sudden change in personality or behavior. Sometimes they can be aggressive at home prior to coming in, and it's very scary to see your loved one like that. Treatment options for delirium is obviously resolve the problem that caused the delirium. And if they're in an acute care hospital, hopefully that's being done. They need more supervision. And oftentimes I'll recommend a one-to-one staff member. And of course, hospital administration does not like that approach because it is costly. But that really eliminates, well, no, it helps reduce the risk of falls. It reassures the patient. There's some consistency. That staff member is there to reorient the patient often, which is very important. We know restraints make delirium worse, and so if you have a one-to-one staff member there, hopefully you can avoid that. It's important to reduce the stimuli in the room. Like if you've got a patient with a lot of family in there, or staff coming in on a regular basis, try to eliminate that, and it's important to keep a routine. Benzodiazepines are not recommended for delirium. It's going to make things worse unless the patient is having withdrawal symptoms from benzodiazepines and alcohol, and that's how it's treated, and then they're delirious because of that. That's a different story. But just they come in with a pneumonia and they develop a delirium. Benzodiazepines are not what you need to do. The medical staff will usually, well, not always, but sometimes they will put patients on benzodiazepines. The patient becomes worse, and then I come in and stop the benzodiazepines, and the nursing staff especially gets frustrated with me because they want them sedated because they're agitated, but that's just going to make things worse. And that's where the one-to-one supervision is beneficial. There's not a lot of support that psychiatric medications help, but if you do need to use those medications, the one that's got the most research and the most benefit is Haldol, in a very low dose, like a half a milligram to a milligram a day, or maybe twice a day at the most. Oftentimes, and that I double checked that today on Up to Date. I said, well, let me see if there's any other research, and I did a quick search. I didn't see a lot of new information regarding that. And that's what we've used for years and years and years. Now, recently, they've been using Seroquel and Risperidol, Geodon, and olanzapine a little bit more, but it's not really any better than Haldol. I use Risperidol some, and sometimes the medical staff will use Seroquel, but really, if you can get patients some Haldol, that's your best option. Of course, it can be given POIM or IV, and that's a benefit as well. Um, so just kind of review that information, especially on those tables. I think that'll be beneficial to you, not only for the test, but in practice as well. Let me talk a little bit about dementia. Dementia is now officially called major or minor neurocognitive disorder, and there's several types of dementia: Alzheimer's type dementia, frontal lobe dementia, which is also Pick's disease, Lewy body dementia, and vascular dementia. The ones we see the most often. This neurocognitive disorders can be caused by other um, problems as well, such as traumatic brain injury, HIV, prion disease, Huntington disease, and Parkinson's. It seems like we've been seeing more and more patients with Parkinson's dementia, or maybe it's being diagnosed more, but I just see it more and more on patients' profiles. There is also mild cognitive impairment, and that's just some early signs of exactly what it says, cognitive impairment. Oftentimes that leads to a diagnosis of major neurocognitive disorder, but not 100% of the time, but oftentimes. Treatment for that is just to maintain overall good health. I don't think that meds are necessarily started right away at that point, but you want to maintain good overall health. The one thing to remember is not to necessarily, when I think I mentioned this a few minutes ago, about when you see that patient in the hospital and they have that acute onset of confusion, don't jump to the dementia diagnosis. Let them get through that medical crisis or problem, and then kind of monitor on an outpatient basis is where that should be diagnosed. Use your screening tools to diagnose. I just posted an article yesterday about a blood test that I think Lilly has it. I have to go back and look for sure, but I think it's Lilly, and the FDA just approved it. Of course, I haven't used it on anybody. It's approved for people 55 and above who have risk factors. I guess in theory anybody could get it, but that's what they approved it for. I don't know what that's going to mean for people. I think some people, it's kind of like the breast cancer screenings. I think some people will want to know and some people won't want to know. Hopefully it can identify the symptoms early and we can start treatment earlier. And I think that's where we'll see the benefit. Oftentimes we see patients by the time they come to us, especially on an outpatient basis, they are pretty progressed, and the medications aren't very effective. And as our population ages, I think we'll see more and more people diagnosed with dementia. And hopefully, if we diagnose it early enough, we can slow it down. Medications, there's a table on page 698 that looks at the medications. It's table 21-56. Take a look at that. We know that with Alzheimer's type dementia, Ruminil, Exelon, Aricept have been used for a while now, as well as Namenda, which is a little bit different. It acts a little bit different. But there's a recommended for mild to moderate impairment. And really, by the time I see patients in the hospital, a lot of times we'll take them off of those medicines. We don't see really the benefit at that point. Vascular dementia, we need to be protective earlier in life. And so I know all of y'all are already nurse practitioners and y'all already talk about all this, but it's very important to take care of our cardiovascular health early in life to hopefully prevent this from happening. And with this type of dementia, you'll see some patients have a lot of good days, and then they'll have some periods of confusion. But overall, there's deficits, and that's when the diagnosis is made. And of course, depending on, a lot of these patients have had CVAs, and according to where that, depending on where that CVA has occurred, then the symptoms can be more severe. Frontal temporal um, dementia usually has an early onset, and you'll see some personality changes in the patient, and family will start to see that, and oftentimes it gets progressively worse. And then there's not a lot of treatment. Sometimes they're just very confused, and um, supervision and safety is the biggest issue for these patients. We want to make sure they are safe. Obviously, we are not going to cure that. So that is kind of my summary of dementia and delirium. I hope this helps. I really didn't do a review for the test. I got some feedback that people were saying that wasn't very beneficial. Like I said, in a few minutes, I will post a study guide as well. The test is pretty straightforward, like we had them in 692. Some application questions, some direct questions. Some of the direct questions are very straightforward, and I just want y'all to make sure y'all know that information and um, can apply it in practice when you need to, which will be just in a few months because you will be finished in August. So, but that will be posted a little bit. That study guide will be posted a little bit later tonight. So if y'all have any questions about the test coming up, let me know. Hopefully this will help. Give me some feedback. If it doesn't help, I'll stop doing them, but hopefully it will. And let me know if y'all need something. Y'all have a good evening.